We're going to sustain this clinical research theme by opening with Professor Parveen Kumar, CBE. She's co-author of the world-renowned textbook Kumar and Clark's Clinical Medicine. Previously, she was Vice President of the Royal College of Physicians, President of the British Medical Association, and President of the Royal Society of Medicine. Professor Parveen Kumar.
Really rather like both Alan and Mike. I'm a massive fan of Saving Faces. It's done so much, I think, for a lot of people. And I think, as John said earlier, without our faces, it's our sort of first, anybody looks at you, they look at your face and then really derives what they think about you from that particular face. Now, I'm a gastroenterologist, so you may well be sort of arguing or saying, what the hell am I doing here? But Ian's asked me to talk about the importance of clinical research, which of course is incredibly important, and I will tell you why. So really, let's just start off with the doctor many years ago, and this is in the sort of late 18th century. And really all we had in those days was compassion, care and empathy and altruism. There wasn't very much we could do, but we were there for the family, and I just hope that we'll never lose that in the future as we go towards this really rather utilitarian, technology-based medicine as we seem to be going. Now, this is all very well, and you've got the microarrays, you've got the mitochondrial antibody there with all the sort of genes you can get, and all these wonderful techniques there. But how do we get there? And the answer is we can't get there without really careful research clinically. And I just want to take you back to some of our forefathers. And of course, William Harvey, who in fact worked at Bart's Hospital, where I come from, and indeed Ian comes from, or we work, was the English physician. And again, by sheer looking at observation of what was happening in your arms, where the veins, which way they fed, and the arteries going the other way, he actually found out about the circulation of the blood. And then John Snow. John, I'm sorry, but there's a H in there, and not you. No doubt you're related, perhaps not. But anyway, John was really probably the first clinical epidemiologist. And I think many of you will remember the cholera outbreak in London, which was absolutely awful in 1854. And what he did was really by careful observation of where the cases of cholera were occurring around London, that he managed to work out that the problem was all emanating from the Broad Street pump. And it transpired that the company that supplied the water to the Broad Street pump was actually taking water from the Thames, but just near the place where all the effluent was actually put into the Thames. And really, he did a major job because he actually managed to get them to change the whole of the water system, which was obviously incredibly important. And then we go on to Florence Nightingale. Now, we all know her as the Lady with the Lamp. They really made nursing a very respectable discipline, a profession. But what we don't remember, of course, is she actually did think about the infection. And if you remember, Thomas's hospital was built in different blocks, mainly so that infection wouldn't go from one block to the other. So she, again, did I always sort of think of her as sort of sitting there for many years, lying in bed, writing 100 missives to the government to try and change something. And then Alexander Fleming. Now, he was a bacteriologist, and he got a Nobel Prize, but in very much a serendipitous way in which he found this fungus, which then turned out to be penicillin. And it was about another 10 years or so, 20 years, before, in fact, penicillin became in use as an antibiotic. And really a very similar, but perhaps recent thing was Helicobacter pylori. Now, I don't know how many of you have heard about H. pylori. Not many. Well, it's a bug. And just to tell you the story, Marshall was a surgeon who was doing a ward round and wanted to do some research. And in fact, Warren was a pathologist, and his boss said, Marshall's boss said, go and see Warren, he's a rather mad chap, he's plating gastric juices to see whether anything grows. And in fact, that's exactly what he went and did. And every day he came in every morning, looked at the plate, there was nothing there, he threw it away. But there was one day when there was a sailing cup which in fact meant that he was away from Friday, Saturday, Sunday, Monday, Tuesday, came back on the Wednesday, looked at it, no doubt with a hangover, looked at it, threw it away, picked it up again and found something growing. So like a true researcher, he took a bit of made a slurry of the bug and swigged it. This is a tricky little customer. This is Helicobacter pylori with little flagellates. But what it did was actually cause ulcers. And he almost died taking that because he got the most terrible, he endoscoped himself and looked at the stomach and it was full of erosions and so on. But remember, before this time, I had spent years looking at acid. And when somebody suddenly said that a bug could cause gastric ulcers, wow, I mean, that was a pretty big thing. And in fact, we can now actually measure the bug, either taking a biopsy from the gut, or we can do it in the stools, or do a breath test. But the reason for telling you about this is that, in fact, it's a class 1, WHO class 1 carcinogen, and the risk, if you have it, of gastric cancer is many, many fold to what a normal population would do. And it is now probably related to all peptic ulcers, apart from those you might get by taking analgesics, which of course you shouldn't do on an empty stomach. And also a lot of people have non-ulcer dyspepsia. In other words, you've got indigestion but not related to an ulcer. A lot of them do actually also have Helicobacter pylori. So the moral of the story is, if you want to get the Nobel Prize, just make sure you don't quite kill yourself, but almost kill yourself, because you might be all right then. So what do all these wonderful people have in common? Well, the answer is dedication and sheer commitment and persistence of what you did. I was just thinking about Florence Nightingale lying in a bed writing 100 missives a day. And also, of course, it's very hard work. But it's wanting to make a difference and trying to solve a problem, and that's called research. And I don't know about you, but what I find about research is that it does actually give you a very inquiring mind. There's rigorous analysis of problems, but also you go into uncharted waters. And it can be basic or clinical, and I think today we want to push the clinical side. But nowadays, for those of you aspiring to do it, and those who don't know perhaps about medicine, but we have established academic pathways to actually get youngsters into research. But at the end of every doctor's, whatever we do, is can we actually give good quality of care to our patients. Now, usually I call research 95% hard work and only 5% excitement, but that excitement, that 5%, is just so wonderful that it actually keeps you going for a few years. But also, it's obviously great fun. Now, in a doctor's life, you can either do clinical work, which you do all the time, you can go into research, or you can do teaching. And of course, you can do a combination of all those. And really, what I think is underestimated is the promise of clinical academics doing clinical research in the field, because that's where observation has such a huge importance. And just borrow from Sally Davis to say that if you take research, you really can start with basic, and that could be science-based, or indeed it could be clinical research. You can go on to translational research, and this is what takes a lot of time, translating what you found into applying it into practice. And the beginning bit obviously is hypothesis-driven, but what you're really trying to get to is solving problems for the patients and trying to get it into the NHS. And the National Institute of Healthcare Research, in fact, has now got a lot of money, as is the MRC. But they fund this bit, and this funds that bit. But this is really where I think clinical research will really take its part. And I was on this committee with Mark Walport, where we actually looked at the academic careers and how can we actually help our medical students, our young doctors, to actually go into clinical research. And I say that, we're remembering that one of the ways we can do research is always by the help of the patients. And in everything we do, we usually have patients either on our committees, but certainly when we're doing research, it's them. And certainly my research, which was in a small bar, was really entirely helped by the patients and their wonderful altruism and actually allowing themselves to be investigated by me and having tubes put down them. It's a pretty horrible thing to do. Now, you take researchers over, and I just want to remind you, I'm a gastroenterologist, and I happen to be teaching and lecturing and looking at some research down in Africa. And an elephant ambled by, and I sort of, he dropped a bit of something down there. And I, of course, was out like a light out of the car to have a look at this. And I think it's just observation of what it was. Now, clearly, it was a huge amount, which I couldn't produce in one fell swoop. But also, you could tell, what he'd been eating, where did he come from? And there was a huge amount of sort of background, and sort of took me back to then looking at, what do elephants do? Well, I don't want to tell you about it, but certainly. But I think it's all about observation, all about clinical stuff, and how you then translate it. And I think for this day, I couldn't think of a better quote than "The future depends on what you do today" at a launch of a brand new research centre. And I think if we can carry on and build on what we can do, we can obviously have sustainable bridges and some that will last centuries. Thank you very much indeed.